Everything letters. Hello, everybody. I think all you are fine. Today, I will discuss some new topics: this hypoparathyroidism and recapitulation of previous studies. Now, hypoparathyroidism is the deficiency of parathyroid hormones due to loss of function of parathyroid gland. The common cause is thyroid surgery, and during thyroid surgery, there may be removal, accidental removal of the parathyroid gland, or maybe loss of blood supply or destruction of the blood supply of the parathyroid gland, which causes the damage of the parathyroid gland and causing hypoparathyroidism. And there is some infiltrating diseases like iron coppers, like hemochromatosis, Wilson's disease for copper. Infiltration in this gland may cause hypofunction of the parathyroid gland and autoimmune polyendocrine syndrome type 1 and the inherited Dijor syndrome. These are the cause of hypoparathyroidism. Now, how will you manage this hypoparathyroidism? There is calcium deficiency, so there may be presence of some features of hypoparathyroidism like tetany, hypocalcemia, and, causing tetany, and mm, there is management, oral calcium salt and vitamin D analogs, and also parathyroid hormones available for subcutaneous injections. Now, pseudo-hypoparathyroidism. This is a condition where hypoparathyroid functionally and parathyroid hormone is deficient in hypoparathyroidism, but here the parathyroid hormone concentration is elevated, mildly elevated, because there is tissue resistance to effects of parathyroid hormone. So, what is pseudo hypoparathyroidism? Parathyroidism, but instead of parathyroid deficiency, there is tissue resistance to effects of parathyroid hormone, such that parathyroid concentration are markedly elevated. একই সাথে there is features of hypoparathyroidism, but parathyroid hormone is markedly elevated. There are several subtypes, but most common is pseudo-hypoparathyroidism type 1A, which is characterized by hypocalcemia and hypophosphatemia, and associated with short stature, short foot, metacarpal bones, and metatarsals, rounded face, obesity, and subcutaneous calcification. This is also known as Albright's hereditary osteodystrophy, and it occurs due to mutation. It is the imprinting mutation in the maternal chromosome GNSA1. So when this mutation occurs, imprinting mutation occurs in the maternal gene GNSI, then causing pseudo hypoparathyroidism type 1. And another term is pseudo hypoparathyroidism. Here the term pseudo hypoparathyroidism is used to describe patients who have clinical features of Albright hereditary osteodystrophy, features of osteodystrophy, but normal serum calcium and parathyroid concentration, which is elevated in case of hypocalcemia with uh, increased parathyroid hormone. But here it is normal serum normal calcium and parathyroid hormone concentration. But there is features of Albright hypertrophic osteodystrophy. It occurs due to parental chromosome mutation of GNS1. Parental chromosome অর্থাৎ মেইলে যদি chromosome mutation থাকে, if there is mutation in the male chromosome, then it will cause pseudo hypoparathyroidism. In the female, it will cause pseudo hypoparathyroidism. Why such thing occurs? Because the main role of homeostasis of calcium or parathyroid hormone is played by the kidney, and kidney solely solely uh, dependent on the maternal gene, but the other parts of the body, the cells are contributed with maternal and paternal both. So if mutation in the female, the kidney cannot handle the homeostasis. So this kind of uh, thing occurs. But in case of male, as female chromosome is escaped from mutation, there is normal calcium and parathyroid concentration. Okay, this hypoparathyroidism or hypothyroidism. Earlier, we also discussed about the hypocalcemia. I will discuss it later uh, in another class. But among the endocrinology system, diabetes mellitus is the most important and very commonly handled or practiced by the physicians in the community or in the population. So we should know diabetes mellitus properly, and also we should practice management of diabetes mellitus, including all the pros and corners of of diabetes mellitus. First, you already know there is three types of diabetes mellitus. It is type 1 diabetes, type 2 diabetes, gestational diabetes, and there is also other specific types. You should remember this causes are of diabetes mellitus. You should remember these causes of diabetes mellitus. This is the classification of diabetes mellitus. Another type is MODY or monozygotic diabetes mellitus. It is maturity onset diabetes of the young and functional deficit. It is a functional deficit. And maturity onset diabetes mellitus of the young are short named MODY, where beta cell glucose sensing is deficit, and beta cell transcriptional regulation diabetes develops during adolescence, early adulthood, and can be managed with diet and tablets for many years. But know that we have a conception that if there is early onset of diabetes mellitus, it is type 1 diabetes mellitus, but the diabetes mellitus of the young may be of these two types also. Now, clinical feature, all you know, that polyuria, polydipsia, polyphasia, weight loss. It is very important feature. Weight loss, unexplained weight loss despite good appetite, suggests diabetes mellitus. And is if it's only this weight loss with good appetite, maybe due to hyperparathyroidism, or maybe due to infectious disease like callas, or due to leishmania donovani. This where there is weight loss, but patient have good appetite, and susceptibility to infection. Patient is susceptible to infection. These are the very important important features of diabetes mellitus. But remember, these features may be absent in a patient with diabetes mellitus also. So we should uh, concentrate our uh, knowledge regarding the diabetes mellitus. And here is some criteria for diagnosis of diabetes mellitus. And it is very important. You are frequently asked by the examiner, how will you diagnose a case of diabetes mellitus? How will you diagnose a case of diabetes mellitus? So you should memorize this thing very clearly, and in any situation you should utter this criteria, and it should be in your mind always, so that you can diagnose a case of diabetes mellitus. Here's some points. Sometimes there is a high plasma glucose, but high plasma glucose like 20 millimole per liter or 15 millimole or 16 millimole per liter, then it is it is a case of diabetes mellitus, unless and otherwise proved anything like glucose saline or etc. So at in this case, how will you confirm it? How will you confirm it? So that it is diabetes mellitus. We receive many prescription with there is OGTT advised a patient with high plasma glucose level, but it is contraindicated. So be careful that how will you diagnose a case of diabetes mellitus. You should know something that will not harm the patient. If you do a OGTT in a patient with 20 millimole per liter of glucose, you you maybe push the patients in a severe consequences. So please remember it always in your mind. First thing, if there is any symptom, or you want to any patient, there is somehow you suspected, and even in a patient who more than 60 or 65 years, then it is our duty to exclude diabetes mellitus, as the incidence increases with ages. Incidence of diabetes increase with age. So this is very important. Fasting plasma glucose. Fasting plasma glucose more or equal to 7 millimole or 126 milligram per dl. Please remember that both parameters, that is 126 milligram per dl and 7 millimole per liter. It is fasting. And what is fasting? No calorie intake at least 8 hours. At least 8 hours, অর্থাৎ 8 to 14 hours we should not take any caloric food. So fasting plasma glucose, it is fasting defined as no caloric intake for at least 8 hours. If it is 7 or more than 7, it is diabetes. Or অথবা if 2 hours post glucose load, দেওয়ার পরে after glucose load, if it is 200 or more than 200 milligram per dl or 11.11 millimole per liter, it is diabetes. And using glucose loading containing equivalent to 75 anhydrous glucose dissolved in water. We usually use 200 to 250 ml of water, 75 gram of glucose, 75 gram, it is not milligram, it is gram. Okay, so it 11.1 or 200 milligram per dl or more 2 hours after glucose load, it is diabetes. Another criteria is hemoglobin A1C. Nowadays it is uttered as A1C. If it is 6.5 or more, 6.5, if it is 6.5 or more, and with this criteria standardization, it is 6.5% or more, then it is diabetes mellitus. This three. And in a patient with classic symptoms, hyperglycemia, what are the classic symptoms of hyperglycemia or hyperglycemic crisis? You know that when the osmolarity is increased, there is diuresis. Increased osmolarity causing diuresis. So polyuria occurs, and there is also thirst or polydipsia. Polyphagia may be present, and hyperglycemia increased substitute infection if it is persist. So if this classic symptoms present, then if classic symptoms plus more than 200 milligram or equal to 200 milligram per dl or 11.1 millimole per liter, it is diabetes. In the absence of unequivocal hyperglycemia, diagnosis requires two abnormal test results from the same sample or in two separate test samples. If there is no evidence of hyperglycemia or no symptoms or anything in the of hyperglycemia, the patient have hyperglycemia in the test, then two tests is required. Two tests is required, and any two of this above yes uh, is confirmed the diagnosis of the diabetes mellitus. Now some terms like impaired fasting glucose. That means the fasting glucose is impaired, but postprandial is normal as it is handled perfectly. So fasting is always is fasting. Glucose is abnormal. If it is 6.1 to 7, less than 7, or the 6.9, 6.1 to 6.9, then it is known as impaired fasting glucose. Another term, impaired glucose tolerance. After glucose load of 70 gram, then if it is fasting is normal, that is less than 7, and after load it is 7.8 to 11.1, not in the mark of diabetes mellitus between 11, 7.8 to 11, then it is known as impaired glucose tolerance. Impaired glucose tolerance. Okay, now how will you manage this case of diabetes mellitus? There's 3Ds, 3Ds, very popular management. 3D: dietary modification, discipline, drugs. Dietary modification, discipline, drug. We sometimes not try to modify the dietary habits. So we are escaping this stage or this portion of management, and we are give emphasis to drug and other management procedures. But it should include dietary modification. A patient have to obey the dietary advices, also lifestyle modification, and next drugs. So these three will control the diabetes mellitus and also control the risk factors for complication of diabetes mellitus. What is the dietary situation constituents recommendation? It is very difficult for our country, but in more first world, it is There is every food has their caloric level and the ingredients, how much they is the energy, that food value there থাকে. But food value is present in the can or boxes. But we are said that diabetes mellitus don't eat any rice or any carbohydrate. Some nowadays it is very popular keto diet, but it is harmful. A diet should have 50% of carbohydrate, 50% of carbohydrate, in which sucrose should be less than 10% and fat less than 35%, and not saturated less than 10%. Protein 10 to 15%, 1 gram per kg body weight. And fruit vegetables 5 portions daily, 5 portions daily. This is the ideal chart for the uh, diabetes patient with diabetes mellitus. Patient with diabetes mellitus. So you should also add 50% carbohydrate in a diet, as this is the easy source of energy. If there is easy source of energy is hampered, then fat will come to make up the crisis, and he fat will yield the energy. And when fat come in forward, there is ketone bodies in the increased ketone body in the body, and this ketone body will encouraging ketoacidosis also. Lifestyle modification, weight management, exercise, stop smoking. Lifestyle modification. Then some drugs. There is two types of drugs: parenteral and oral medications. Parenteral insulin and GLP-1 receptor agonist, exenatide, liraglutide. Please remember the names. Remember the names. You may GLP-1 receptor, you may utter GLP receptor agonist, and you may ask for please name some GLP-1 receptor agonist. Then you should tell this names. Similarly, this metformin, only one biguanide available for use. Then sulfonylureas, these three types, three sulfonylureas, three types. There is difference in their duration of actions. GP4 inhibitors, incretins like gliptins, meglitinide, SGLT2 inhibitors, canagliflozin, empagliflozin. Nowadays, it is come forward as each has a property, and the study shows that there is a significant reduction of the cardiovascular complications. Significant reduction of the cardiovascular complication, but drawback is urinary urine infection, urinary tract infection, as it prevent glucose to reabsorption and excreted through the urine, and glucose is a good media for bacteria to grow. So there is increased incidence of urinary tract infection. Roglucide acarbose inhibits absorption of the carbohydrates, and thiazolide induces insulin sensitizer. And insulin, how when you should think for treat a patient with insulin, when you should think for treat a patient with insulin. Here is some indications. Type 1 diabetes mellitus. Why type 1 diabetes mellitus is mandatory to treat with insulin? Because it, in this case, there is absolute deficiency of insulin. absolute deficiency of insulin. So patient is getting insulin deficit, and pancreas cannot produce insulin. So there is need for replacement of insulin, and without insulin patient will not survive. And this is a one criteria that without insulin, the patient with type 1 diabetes mellitus will not survive. Now, evidence of ongoing catabolism, weight loss. Patient presented with the symptom of weight loss. Patient complaining weight loss despite good appetite. Weight loss despite good appetite, and in this case, patient should go for insulin. Symptoms of hyperglycemia are present. If there is all symptoms of hyperglycemia, there is polydipsia, polyphagy, there is polydipsia, polyuria. So what is polyuria? Sometimes we mistake that increased frequency, increased frequency as polyuria, but polyuria means more than 3,000 or more than 3,000 ml or 3 liters of urine more than in 24 hours. If it is more than 3 liters, then 3 liters or more than 3 liters, it is polyuria. But increased frequency may not polyuria. To pass 3,000 ml urine, uh, you should have increased frequency, but all increased frequency of urination may not associated with more than 3 liters of fluid uh, voiding or urine voiding. So some condition where there may be increased frequency, but there is scanty micturition like urinary tract infections. So it is not polyuria. Urethritis. So it is not polyuria. The volume should also increase. Infections. Hyperglycemia, another presentation is infections, associated with infections. If this is present, then go for insulin. If hemoglobin A1C is more than 10%, if A1C level is more than 10% or 10% or more than 10%, then you should go for insulin. Previously, it is 8% for some years, then 9 or 9.5% for some. Nowadays, it is called that A1C should be 10%. If A1C is 10%, then if there is presence of other features or not, patient should take insulin. If blood glucose level is 300 or more, or 16.7 millimole per liter, you may go for insulin, as well as there is presence of hyperglycemia, symptoms of hyperglycemia. These are the indications of insulin. Type 1 diabetes mellitus, evidence of ongoing catabolism or weight loss, symptoms of hyperglycemia are present, A1C level 10% or more, blood glucose level 300 or more or 16.7 millimole per liter. There is different insulin preparations: rapid acting, short acting, intermediate acting, long acting basal insulin by analogs. These are the glargines, datimer. This insulin is nowadays used very frequently and is recommended for using these patients diabetes mellitus. At it is important in controlling diabetes mellitus. Should fasting plasma glucose should come in control to control the other throughout the days. Fasting is our target. If fasting is controlled, then there is some peaks after food. There is some peak after food food in the plasma glucose curve, and these peaks are cut off by this short acting soluble insulin or insulins rapid acting insulin or short acting insulins are cut these peaks. And there is throughout the day there is desirable control of the blood. And this insulin has a character that it releases continuously in a steady manner, that there is no hypoglycemia, no peak. It has no peak. There is maintained sustained plasma glucose level. So there is less chance of hypoglycemia as there is no peak. But this uh, this insulin has peaks. There is peaks this time, and at that point there may be chance of hypoglycemia, but it has no peak, and act 18 to 26 hours. Okay, insulin. You should know the insulin names of the insulin. You are frequently asked for name of the insulins. Now, how to inject insulin subcutaneously? It is very practical. You should know the how will you uh, subcutaneously. There is specialized needles for giving insulin, and it should be right angle to the skin. Right angle to the skin. If it is not right angle to the skin, it may be intradermal. It may be intradermal injection, and then there is a difference of absorption. So, in the needle should be right angle to the skin, subcutaneous, not intramuscular injection. Another, if it is not right angle, it may be intradermal, or if it is too much too much, then it may be intramuscular. It also not recommended. So it is you should know how to give insulin. Delivery device as a glass syringe and pen device, infusion pump, many delivery devices. And side effects of insulin. First side effects is hypoglycemia, and during management to achieve the main uh, main thing that prevent or main thing to prevent strict glycemic control is hypoglycemia. For this reason, sometimes strict achievement of strict hypoglycemic control cannot be achieved. Weight gain, insulin because weight gains, there may be peripheral edema, insulin antibody and resistance of the insulin may occur. Allergy, very rare nowadays, as it is a recombinant technology. And previously bovine insulins are used, which is causing allergy. This is now very rare. Hypertrophy or lipodystrophy, injection site. Hypertrophy, the injection site. Incretin-based GLP-1 agonist, and gliptins, sitagliptins, vildagliptins, linagliptins. So, these names are important. Please remember these names. And incretin-based, these names, you should know these names. Metformin, it is very important, and it also reduces weight and controls mainly the fasting glucose levels. And metformin, when you cautious administration of insulin. Okay, one thing is metformin can increase susceptibility to lactic acidosis. It is very grave condition. Lactic acidosis mortality is very high. So if there is any chance of lactic acidosis, please omit metformin. Like severe stress, infection, such. things. And metformin itself increases substantial lactic acid basis. It should be omitted temporarily during any acute illness. For this reason, it should be omitted temporarily during any acute illness. In case of any acute illness, you should not administer metformin. After getting improved of the acute illness, then free from acute illness, then you can institute the metformin. Should not be used below an eGFR of 30 ml per minute per 1.7 meter square. eGFR 30 ml. Contraindication in patients with significantly impaired hepatic function and in those who drink alcohol in excess. They should not give metformin. There is chance of lactic acidosis. Sulfonylurea, glycoside, glimepiride, glipizide, lebenclamide. These are the sulfonylurea gas, different duration. It is a secretagogue, increased secretion of the from the pancreas. SGLT2 inhibitors, sodium and glucose transporter 2 inhibitor. It is reabsorption 25%, filtered glucose not being reabsorbed 25%. যে সিক্রেটেড গ্লুকোজ যেটা কিডনিতে হয় সেটাকে আবার রিঅ্যাবজর্পশন করে নেয়, তার 25%কে সে রিঅ্যাবজর্পশন করতে বাধা দেয়, 25% not reabsorbed, so lowers blood glucose. It has also reduction cardiovascular therapy results in a 35% reduction in cardiovascular mortality. Carbohydrate absorption, alpha glucosidase inhibitors, acarbose, and as a lead receptor synthesizer. Glycemic target. What is the glycemic target? When you treat the patient, you should have mind that this is my target. Then you will treat the patient. What is the target? A1C, fast follow A1C, which is done 2 months to 3 months apart, and it is 7%. Why it is not 5% or 6%? If it is 5%, then it will be more beneficial for the patient, and there may be more beneficial for the patient, and there is no complications of the diabetes at all. She is like normal person. But why not target is less than 5% by 6%? Yes, it is target is less than 7%, but at least 7%. Why? Because diabetic patient have some complication, cardiovascular, macrovascular complications, which is now silent. But when you try to strict control like 5-6%, then the aggressive drug, anti-diabetic drug may cause frequent hypoglycemia or hypoglycemia. This hypoglycemia may cause if there is ischemic heart disease, may cause myocardial infarction, and in few years back it is 6.5 also, but in studies, different studies say that if it is 7%, less than 7%, the mortality is high, but when it is targeted 7%, the mortality rate is calm. So less than 7% in general causing increased mortality due to diabetes mellitus. So target is 7%. A1C. P-perennial capillary plasma glucose. Capillary plasma glucose is 4.4 to 7.2. It is 4.4 to 7.2. This is the pre-perennial, the fasting capillary plasma glucose হবে আমার 4.4 to 7.2 millimole per liter, 80 to 130 milligram, and postprandial 2 hours plasma capillary, 2 hours postprandial, but 2 hours after food, it is 10 millimole, less than 10 millimole, so not 10, less than 10 millimole, 8 by 180 milligram per liter, or less than 10 millimole. This is the target. This is very important during management of diabetes mellitus. But I told that it is 7%. But when more strengthened and less strengthened, in some situations, you should try to take the 7% glycemic control A1C less than 7%, and in some cases it should be more than 7%. 7%. Okay, like risk potentially associated with hypoglycemia and other drug adverse effect. যদি কম থাকে, then 7 less than 7% is our target or আমাদের desired A1C. যদি this potentially বেশি থাকে, increase or more, then it will be more than 7% is desirable, or more than 7% is acceptable, not desirable. More than 7% is acceptable. Disease duration, more duration than our says more than 7% is acceptable. Newly diagnosed case, as much as low the A1C level, less than 7%. Or life expectancy, long life expectancy, less than. Low life expectancy, short. This is the important comorbidities যদি absent থাকে, then less than 7%. Okay, বেশি থাকলে, সিভিয়ার থাকলে more than 7%. Patient performance যদি motivated থাকে, excellent self care possible থাকে, self care possibilities, excellent self care possibility, then it is less than 7. Why? What is the excellent self care? Motivated is a diabetic. I want to control the diabetes mellitus, physical and lifestyle modification, drug modification, sorry, dietary modification, lifestyle modification, and very alert about the glycemic, hyperglycemic and hypoglycemic attacks, and know how to control these things. Then he may be less than 7%. Resource and support system যদি available থাকে, তাহলে more, if it is available, then less than 7%. Now complications, there is some acute events like diabetic ketoacidosis, hyperglycemic, hyperosmolar states, lactic acidosis, hypoglycemia. Diabetic ketoacidosis, hyperglycemic, hyperosmolar state, lactic acidosis, hypoglycemia. I will not discussing this all things, but these are the acute, and it is also very it should also managed very carefully and very rapidly. There is long-term complication, macrovascular complication, coronary artery disease. You are asked how name some macrovascular complication, then the answer will be coronary artery disease, peripheral vascular disease, stroke. Coronary artery disease, peripheral vascular disease, stroke. What are the microvascular complication? Microvascular complication, retinopathy, nephropathy, neuropathy. Retinopathy, neuropathy, nephropathy. Retinopathy, neuropathy, nephropathy. Microvascular complication. Ketoacidosis, hyperketonemia, 3 millimolar বেশি যদি থাকে, ketones and ketonuria 2 plus, hyperglycemia 10, more than 10, 11 or more, and metabolic acidosis, bicarbonate less than 15, or pH less than 7.3. This combination of this will say that it is diabetic ketoacidosis. Patient hyperosmolar stated features. thirst, polyuria, thirst, weight loss, weakness, leg cramps, blood vision, nausea, vomiting, abdominal pain. Clinically, there is dehydration, hypotension, cold extremities, tachycardia, hunger, Kushmal breathing, acetone breathing, hypothermia, delirium, drowsiness, coma. Issues here. So the management is you should practice this management. Hyperosmolar state, millimole, 30 millimole. Hypovolemia, severe hyperglycemia, usually more than 30 millimole per liter, and hyperosmolarity, serum osmolarity more than 320 milliosmol per kg. There is a direct method of see the osmolarity, and another is indirect or calculatory method, calculation করে measured method, and another is calculatory method. Here is sodium plus potassium into 2 blood urea in millimole plus RPS plasma glucose in millimole. Then the osmolarity management. Hypoglycemia is defined as blood glucose of less than 3.9 millimole per liter. And hypoglycemia resolved by giving glucose. There is sweating, pounding heart, hunger, anxiety, autonomic. একটা patient কে তাহলে we should we should mm, we should ventilate the education during treating diabetes mellitus, that if there is sweating, trembling, pounding heart, hunger, anxiety, consider hypoglycemia. Check blood glucose. Or if it is not available, please take snacks or up to according to the severity. You may take glucose. Also, neuroglycopenia, delirium, drowsiness, speech difficulty, inability to concentrate, incoordination, irritability, anger, Diabetic patient may become irritated and anger. Mm. Then you should don't irritate the patient further, or please don't mind. This is due to this hypoglycemia, irritability, anger, non-specific nausea, tiredness, headache. This may be non-specific symptoms of hypoglycemia. Uh, Hypoglycemia is oral fast-acting carbohydrates, glucose 10 to 15 grams, take as a glucose drink or tablets or confectionery. Repeat capillary glucose measured 1 to 15 minutes later. If still less than 4 millimole liter, repeat above treatment. If blood glucose remains after 3 cycles, consider glucose 1 milligram IM or 150 to 10% glucose over 15 minutes IV. Once blood glucose is more than 4 millimole, take additional long-acting carbohydrates of choice. Do not omit insulin injection if due, but review regimen. If patient is semi-conscious or unconscious, parenteral treatment is required. What is severe hypoglycemia? If patient cannot take his own treatment due to hypoglycemia, own treatment of hypoglycemia, then it is severe. If his self-medication cannot be possible, then it is severe hypoglycemia. There is semi-conscious unconscious patient, parenteral treatment 75 to 100 millimole 20%. IV 75 to 100 millimole 20%, dextrose over 15 minutes. Okay, and injection glucagon IM 1 milligram. Is conscious and able to swallow, conscious, give oral refined glucose as drink, sweat 25 gram. Tablets of glucogel. I omit this neuropathies. Clinical features autonomic neuropathies, postural hypertension, resting tachycardia, fixed heart rate. These are the autonomic neuropathy features of autonomic neuropathy feature. How to take postural hypertension, blood pressure to see postural hypertension, resting tachycardia, fixed heart rate, dysphagia, gastrodysphagia, abdominal fullness, diarrhea, nocturnal diarrhea, fecal incontinence, nocturnal diarrhea. A diabetic patient may come with nocturnal diarrhea, constipation, genitourinary difficulty in micturition, autonomic neuropathies, diabetic food, very important for clinical practice. Okay, this is the food care. I also tell you there is a charcot food. There is neuropathic joint. There is no sensation, so there is destruction of joints. But amazingly, there is swelling, there is damage, there is deformity, but pain is absent. Charcot food. This is charcot food. Pain is absent. This arthritis, but pain is absent. Neuropathic ulcer in the pressure point. This is the compensatory. Is pulseless, so there is gangrene of the foot. Diabetic kidney disease, proteinuria. Early microalbuminuria. Early morning urine is measured for the albumin creatinine ratio. Microalbuminuria is present if if in case of male, if it is ACR is 2.5 to 30 milligram per millimole creatinine, then it is microalbuminuria. In case of female, it is 3.5 to 30 milligram. 3.5 to 30 milligram millimole per kg. Or more than 30 milligram, it is microalbuminuria in case of male and female. Male 2.5 to 30 milligram millimole per creatinine, then it is microalbuminuria, and male is a female 3.5 to 30 milligram per millimole creatinine. If female 2.5, it is not microalbuminuria, and more than 30 milligram, it is albuminuria, proteinuria. Elevated assay should be followed by a repeated test. There is established microalbuminuria if 2 out of 3 tests are positive. First impression should not give the conclusion. You should do a 3 tests, consecutive 3 days, 3 tests, usually 1 month apart. Elevation should be followed. An ACR minimal creatinine is consistent with overt nephropathy. Once a year assess albumin, প্রতি বছর দেখতে হবে। Risk factor for diabetic nephropathy: poor glycemic control, long duration of diabetes, presence of other microvascular complications, ethnicity, pre-existing hypertension, family history of hypertension. If these are present in a diabetic patient, he is prone to develop diabetic nephropathy. Glucose control, optimize blood pressure, ACE inhibitor ARB. Why we choose ACE inhibitor or ARB in a patient with diabetes mellitus if there is no contraindication? Because it reduces proteinuria and prevent nephropathy. It reduces proteinuria, prevent nephropathy, retinopathy. Okay, you should read this thing. I also already discussed the previous lectures. Diabetic classification, diabetic retinopathy. You should know. Nice to know things. If you know it, it will be help you to do for a good management, good glycemic control, always get appropriate pressure maintained, anti-angiogenic ranibizumab if needed when it is proliferative, retinal photocoagulation, proliferative disease, gestational diabetes mellitus. Diabetes mellitus was defined as an degree of GDM. GDM was defined as any degree of glucose intolerance that was first recognized during pregnancy, regardless of the degree of hyperglycemia. ফার্স্ট ইনটলারেন্স যদি গ্লুকোজ দেখা যায় প্রথম in case of in a pregnancy, during pregnancy, then it is GDM. There is some diagnostic criteria for GDM. Fasting 5.1. Diagnostic criteria for GDM, risk factors, body. Okay, thank you everybody for patience hearing.